ukirende umfwa umutwe bata wale kalipa sana mambo musane wale kalipa sana so nayimine nambo kulaya ku kliniki 2204 ilo na papi after kupapa nalisa blida sana nalisa umfa nolunshingwa sana umutima wali chita wali papa uka sana ofo nalele mudia uluchero pakofu yaishile nshita yakwisa mkunsenda bakunsenda ilo baishile nsenda past 11.
Jeg fik de første vejer ved 9-tiden, og klokken 12:30, der kørte vi herop. Vi har 5 minutters kørsel til sygehuset, så der kørte min mand herop. Og så kom jeg ind på fødestuen, og så er han født 18 minutter over 2. Goddag. Lone.
Hvordan går det med jer?
Det går fint. Da det er mit første barn, så er man meget nervøs for, om det hele det nu kan lade sig gøre med amning og skift, og om man gør det hele rigtigt. Så derfor har jeg valgt at blive på sygehuset i 4-5 dage, tror jeg. For det giver en vis tryghed, så man kommer hjem til dagligdagen. Så vi bliver her et par dage og får noget hjælp.
Two children come into the world, a world where globalization is changing the living conditions of millions of people forever. A world in which the same images and events reach people in every corner of the world, creating new needs and perhaps greater understanding. The two babies were born into a world full of new opportunities, but not for everyone. Despite globalization, the gap between rich and poor is widening. In the field of health, that gap is costing lives.
We really are standing by as millions of people die every year.
The American Jeffrey Sachs is one of the world's leading economists. For 2 years, he chaired a commission set up by the World Health Organization. The Sachs Commission was charged with charting the link between global economy and health.
For the first time in history, we could actually solve the problems of absolute poverty, as we have in our own societies, after all, in the United States and Europe. Not that there aren't some that are relatively poor, but people don't have to die anymore for lack of food, for lack of access to the most basic life-saving medications. And we can do this on a global scale, perhaps for the first time in history. We are so rich, we are so capable right now, if we put our attention to that.
Asame insan. Landenati Okay, chap. Okay.
In Zambia's Mpongwe district, Malan Soko is a doctor and medical director. He and his few staff oversee a huge area where they help as many lives as possible. But money is short. Malan Soko only has $12 a year for each of the district's 66,000 inhabitants.
The majority of the clients and patients that we see are actually children and young adults. It's rare to see so many elderly people. I'm sure when you went around the world, you might have noticed it's 1 or 2 elderly people on the beds. Our healthcare system is, I think, much of its emphasis and effort is taken up in saving the lives of young children and young adults that are sick.
One of Malan Soko's responsibilities is the supervision of the health centers in the area. It's there, at these centers out in the country, that by far the most Zambians come into contact with the health service. But about half of the population never visit a doctor or a clinic. On average, Zambians come into contact with the health service less than once a year. In Denmark, the population are in contact with the health service 7 times a year. At the clinic in Kanyenda, Kandala is the midwife who sees to the pregnant women who make it to the health center.
Most of our mothers, due to the long distances from the health centers, will deliver in the villages. And then that usually ends up in complications. See, a mother might bleed a lot in the village until they maybe find a bicycle or an ox cart to bring them to the hospital. And it takes time for us now to get in touch with the hospital, and the hospital has to send an ambulance. So maybe by the time the woman reaches the hospital, she might die on the way.
In Impongwe, there are no spectacular pictures of famine or need. The district is the epitome of normal life in Africa, where every day it is debilitating poverty that rages. 4 out of 5 Zambians live below the national poverty line of $1 a day.
The commonest way in which people get income here is when they sell their produce from their small farms. And so around this time, when they've got a bit of maize, they would have a bit of cash. But around, starting from August, September, October, the household would really have basically nothing in terms of cash. On an average, income in a household would be something like $25 in a month. That's the amount of cash that the family would have to use for health services, schools for children, and general upkeep in the house. Most of them are not able to make ends meet in a month.
Modi Bobo and her mother are cooking supper. They have few ways of varying their diet. It consists almost entirely of maize porridge. With newborn Blandina, there are now 7 mouths to feed, and the family only gets by because it has a small plot of land on which Benius Bobo grows maize. But although the family can keep the worst pangs of hunger at bay, illness is an everyday occurrence.
Okababa kulunga balwalaba ilingi bawishi bala bautifila fine nomba ndashupike fya kwenda nabo ngalwadisha bantu limbikula batsama katakwete nomba transport ya kumusendera kwelingira nshupako ilingi balwala sana munani mumainza ilo balwala sana filanga kuli mosquito komanga muno nopo ali ukongere number 3 number 4 yena ndampapa namutala kliniki nombaba imyenderera nshupa sana.
When a child is suffering from malaria but it has also got malnutrition, it is also an underlying cause for all these. No matter how much you give them the treatment in the hospital, when they go back, they are malnourished, they will respond very poorly to the next episode of malaria, and in any case, to recover from the previous episode of malaria in terms of anemia building up their HP would still be a problem. So I think socio-economic factors surrounding our health problems are the many reasons why the under 5 mortality rate is still rising in our country.
Så det er jo utrolig vigtigt, at han ligger på maven, fordi det gør ham stærk i ryg og arme. Vi kommer som regel, når barnet er 10 dage gammel, og så igen måske en enkelt gang inden 5-ugersundersøgelsen. Så er der 5-ugersundersøgelse ved en læge, og så kommer vi ved 2 måneders. Så er der mange af mødrene, der går i mødergruppe, og der giver vi kostvejledning i mødergruppen og ser familierne der. Så er det tit, at vi besøger familierne igen, når børnene er omkring 6 måneder, og så 8 måneder.
Jamen, jeg synes, det er rart, at Tony hun kommer her, og hun er både kritisk, og hun giver ros, og hun tjekker, at han har det godt, og er opmærksom på nogle ting, som jeg måske ikke lige har været opmærksom på. Man har nu for eksempel nogle bekymringer om, han nu tager ordentligt på i vægt og så videre. Det synes jeg, der er det rart, at man har sin sundhedsplejerske, man kan spørge. Og hun er også god at snakke med, fordi hun tager sig tid til os begge, kan man sige.
You know, in the United States now, we're spending about $4,500 per person every year on average for health. In a country like Malawi or Tanzania or Ghana, it's maybe about $10 per year. So we're talking about gaps of hundreds of times. In poor countries, people may never see a doctor. They may die of easily treatable conditions. In the rich world, life expectancy has arrived at 80 years or more. In the poorest countries, life expectancy is falling below 50 years, and in some cases where AIDS is running rampant, below 40 years. So these gaps are startling in the 21st century, but they're also widening.
Zambia is one of the few places in the world where infant mortality is on the rise. 1 child in 5 dies before the age of 5. The most common causes of death are malaria, pneumonia, diarrhea, and respiratory infections. Almost half of Zambia's children suffer from irreversible conditions caused by chronic malnutrition and undernourishment. There are few resources for vital preventive efforts.
We are supposed to invest so much in the prevention so as to avoid these diseases occurring, but it's like we are spending too much in the curative side than the preventive side, as you can see. I have a good number of patients outside. Most of them are just malaria cases. We have to buy chloroquine or antimalarials in general, hemopoetics or drugs to treat the anemia, which comes as a complication. Then there's the referrals we are just talking about. At least money has to be sourced. Then bed occupants rate also on our wards. See, and yeah. Really, much of the resources are channeled in the curative side than the preventive side.
Although the Zambian Health Service has little money, lives are saved. Health clinic staff make tremendous efforts, and parents often spend a whole day getting their children to the clinics. Nowadays, 9 children in 10 are vaccinated for diseases like tuberculosis, measles, tetanus, and polio.
I think there's an improvement in that most mothers now know the goodness of coming to a health center. So they will try by all means to come to the health center. When they come to the under 5 clinics, they have their babies vaccinated against the preventable diseases. We'll advise them on the rightful diet for the babies. So in that way, I think there has been an improvement.
When Zambia gained its independence in 1964, its leader, Kenneth Kaunda, had great visions of economic growth and social equality. Zambia was the 2nd richest country in Africa, south of the Sahara, and its wealth was based solely on revenues from its copper mines. But in 1970, the price of copper crashed. The mines were nationalized without being modernized, and output slumped drastically. By 1990, the decline was complete. Zambia was the most heavily indebted nation in the world per capita, and in return for help, the International Monetary Fund and the World Bank insisted on heavy cuts to public services and the opening up of Zambian markets. The purge hit the poor hard, and economic growth failed to materialize. Today, there are 450,000 paid jobs to be shared by a population of more than 10 million.
Oh, 1,015.
The Christian NGO Jesuit Center for Theological Reflection in the capital Lusaka has been pleading for the poor's case for many years. The organization keeps a record of the prices of staple foods, and the monthly review shows time and time again that even Zambians in work cannot afford the basic necessities for their families. And globalization has not improved matters.
Ever since the advent of globalization, I think Zambia has emerged a loser. Why has it emerged a loser? One has to look at, for example, the question of trade. We have opened up our markets. It's an open door policy. Now, through that open door policy, we have seen our local industries folding up. That has been accompanied by huge job losses. We have seen that a lot of goods that are able to be produced cheaply elsewhere are coming into the Zambian market. How many people are in employment? How many people are earning anything so that they can be able to buy? If there is any aspect from the Zambian perspective that is very conspicuous in relation to globalization, I think it's the issue of poverty. We have seen from the time that this economy was opened up, we have seen also an accompaniment of poverty increases.
Some ideologues, I would say, like to believe that if you just wait and leave things alone, that the poor will catch up eventually with the rich, or at least they'll be able to narrow the gap. But the evidence is that hundreds of millions of people are absolutely trapped in extreme poverty. They're facing a vicious cycle in which poverty leads to disease, illiteracy, environmental degradation, and that leads to another generation of poverty. And so they're not getting out of it simply by watching the markets work. I believe that market forces can help, but not if they're not augmented by direct and concerted investments in social priorities, and especially in the health and the education in the poor countries, which are vital investments needed to break that vicious circle of poverty, disease, and illiteracy and environmental degradation, which is leading to this continuing decline in many of the poorest places in the world.
In Chibolya, one of Lusaka's slums, people know what it means to be trapped in the vicious circle of poverty and disease.
Uyu eze pa accident anagwenza natyoka manja. Uyu eze hospital kwenze kumulembera mankhwala. So pala namchosa futi timperekeko namulembera mankhwala futi yo ya 37.5 kozi chosa ndrama zinatiso. So kulibe tinkhala chabe so kulibe umetinga sichosa ndrama.
Sick people aren't productive. I mean, if in your household the main adults are ill frequently, if the children are ill so that the adults have to look after them, if they have to spend money on treatment and so on, then they are unable to work as hard as they might otherwise be able to. Maybe they can't plant in their fields or clear the weeds from their fields because they're ill. More broadly, the more unhealthy a country, the less likely is there to be international investment, for example. Expatriates are less likely to go there. The tourist industry may not take off if people worry about malaria or HIV. So at both the household level and the level of the economy as a whole, there are very clear ways in which poor health hampers the economic development of countries.
Poverty doesn't only prevent the sick from recovering, it also destroys young people's chances of an education. Basic schooling is free in Zambia. Pupils have to pay for uniforms and other expenses, but only 7 school-aged children out of 10 actually go to school. and the lowest average is amongst the poor.
That has got serious implications in terms of the overall national development of the country. So you find a household being confined to making a decision on the basis of what is happening today and not looking at the future of their children. They want to see that today, because we are unable to send a child to school, they have no option but to withdraw that child from school so that that child can even participate in household economic activities and perhaps even contribute something to the household.
Zambia's decline from being one of Africa's richest countries to one of the world's poorest has naturally had serious effects on the health sector. The NGO Women for Change monitors developments in the health field closely. Justina Munga is a nurse and employed by Women for Change.
After independence, we saw a lot of hospitals, a lot of district hospital centers, health posts, and many other healthy facilities being built. We had very good training for health personnel, nurses, doctors, clinical officers at all levels to man the health services in Zambia. In the last decade, we are seeing a reverse. A lot of qualified personnel in health services migrated because of the poor conditions of service, because of the poor work environment. A lot of them migrated to the neighboring countries and abroad to seek job satisfaction. If you have to go for a simple operation in a district hospital, for example, you'll be asked as a patient to buy most of your requirements, from a surgical blade up to suture materials. How many Zambians are able to manage and be able to buy all this for their own health facility?
Health services in Mpongwe district function satisfactorily in Zambian terms. Nevertheless, work is not easy at the health centre in the small village of Kasamba. Isaac Mubita is a qualified environment and hygiene technician and in principle ought to be working with 3 other qualified health staff at the centre, which serves a population of 6,000. But Isaac Mubita has to perform the responsibilities of the centre manager, midwife and nurse, helped only by an assistant with a couple of weeks' training.
Here there is no transport, there is no bus, there is no car, there is no vehicle. The only transport that we have, or means of transport, is the bicycle. Here we don't have lights. Then telephone we don't have even a radio. So for us to communicate with the district, we have to walk ourselves we have to travel to the district. Then we discuss any issue that is pertaining our work. But no way of communication apart from just seeing them personally. It is bad because since communication is a problem and the clinic is understaffed, transport, there is nothing. Now we find some problems, especially when we have a serious case which needs the hospitalization. So we have a problem because we don't have a radio to radio the district to send an ambulance. But some of the diseases we attend to here were supposed to be attended to by doctors. Now, because the distance from here to hospitals is very far. Anyway, we manage those cases, and those who are lucky, they get cured.
Ja, værsgo at træde nærmere. Nå, du bliver træde indenfor. Og sid ned over på den side af bordet.
Ip Bukbjerg is a doctor at Riis Hospital, Copenhagen. He has been working within health in developing countries for over 30 years.
Når jeg sidder og vaccinerer et rask menneske imod noget, som de overhovedet ikke fejler, og som de højst sandsynligt heller ikke kommer til at fejle, Og jeg smider om mig med engangssprøjter og vacciner, som er opbevaret efter kunstens regler. Og så bagefter befinder jeg mig i Tanzania i en lille helsepost, hvor at de igen ikke har fået deres forsyninger af sterile sprøjter og kanyler, og hvor der ligger sådan nogle af de der nåle, man kommer ind i over til, og når man skal give blod og væsker. Og dem bruger man jo normalt en gang, hvor de så har ligget i en desinficerende væske, så tager man dem op en gang til, og så desinficerer man dem en gang til, og til sidst, når man skal prøve at komme ind i huden, så er de blevet så sløve, så nålen forsvinder baglæns op i slangen. Så er man ude på kontrasterne.
If Zambia was my patient, my diagnosis would be that this patient is suffering from poverty. And the solution to that patient lies in alleviating that poverty. So all the things that it takes to alleviate poverty for a country would be the things that I would prescribe as my treatment to Zambia.
One of the most important conclusions within the Sachs Commission's report is that it makes economic sense for the rich countries to invest in healthcare in the poor countries.
The message I want to underline is that in the poorest countries, spending more money on health is incredibly cost effective. It's also, I should add, which is one of the main messages of the Commission's report, very good for economic development. The main message of the Commission's report is not only that we have effective interventions that are highly cost effective, but also if we can achieve high coverage of those interventions, then there will be considerable positive impacts on economic development.
Millions of people are dying every year because they lack access to the most basic life-saving health interventions. For $40 per year on average, one could address AIDS, one could address malaria, one could address tuberculosis, one could keep children from dying of diarrheal disease or respiratory infection. Our estimate is that if the donors and the poor countries mobilize the resources together, you could avert about 8 million deaths every year as a result of this increased investment in health.
There's no way the rich can stay with all the basic and all the comfort they are living in and leave the poor dying the way they are because of poor conditions. If the international community does not deal with that, I'm afraid we are going to have an empty Africa and an empty Zambia.